Okay, so your question is, research into vestibular functioning and perception will inevitably lead to the conclusion that it's a miracle that we can find our way home at all. Is that true or false? Let's see what the result is. 86% agrees.
Not much to do.
No. I don't know.
Hi, my name is Mert. I work for the Military Rehabilitation Center located in Doorn in the Netherlands. And first of all, thank you for having me here and having the possibility to share my research with you. First slide, please. Okay. There was. I haven't called my presentation finally motion-based equilibrium reprocessing therapy. That was my PhD thesis. I finished last year. I have some copies, hard copies left and right, so if you're at the end of this presentation thinking, well, that was mighty interesting, just grab a copy. And for those of you who don't have a if there's none left, I can also send you a digital format if you mail me at this address. So my presentation is about motion sickness, vestibular disease and sensory motor integration. Next slide, please. Well, I work at the Military Rehabilitation Center and there are 3 physiatrists in the Netherlands, military physiatrists. We treat about 1,200 patients per year. Reaching from 6 weeks or a few weeks to more than a year in therapy. We specialize in trauma, orthopedics and neurology. And our research facility is called the Center for Augmented Motor Learning and Training, where we do stuff on, with virtual reality. We try to do some international collaboration. We have a collaboration going on with the Canadian Armed Forces on post-traumatic stress syndrome using virtual reality. And just recently we started a project with the Belgian forces on low back pain. Well, as a physiatrist, before I go into the presentation, I see a lot of low back pain patients, and I think quite a lot of you also. And you think, well, it's quite a burden those people have to go to, and then sometimes you just see stuff and you think, well, maybe it's what is low back pain at all? Could I see could you start to film, please? Kind of broadened my perspective on low back pain. So, yeah. Okay. Next slide. So, get down to the presentation. This one we have seen before this evening, in the morning. It's a study done by Macaulay and O'Hanlon and Macaulay in 1974. They used 500 patients, and they and about I thought per data point 20 patients. What you see here is the motion sickness incidence, the frequency of the motion and the acceleration, and you see at about 0.2 Hertz with linear acceleration, vertical this one was, you see a maximum motion sickness incidence, and which is increasing with increased acceleration. Typically this 0.2 Hertz is pretty close to normal breathing frequency of 12. So I wondered if there's any relationship with breathing. Is there maybe enforced breathing by the motion, so that you start to hyperventilate and maybe it influences those symptoms? So is it motion sickness at all what we see? So, and there's a large symptom overlap between hyperventilation and motion sickness. Next slide, please. So we did 3 experiments, one on a Barani chair, one on a ASA sled. It's a sled that can go back and forth, and the gimbal here can also turn a bit. And this is the disdaemona. Well, you've seen this a few moments ago. I was thinking about a fourth experiment, but my wife did not approve of this. But I was able to do a small pilot experiment, so maybe you could watch it. And well, that's my daughter. She was 2.5 there, and yes, well, but she's quite. It doesn't bother her a bit, and as we all know that with the evolving vestibular system, we get with age at about 12 years a peak in motion sickness incidence. So if you're sitting in the back of the car, etc. Yeah. Well, and there she goes. So the ethical committee did not approve of this, of course. Yes. Okay. So next slide, please. Yes, next slide. Yes. So the first experiment we did was on a rotating chair. I chose the rotating chair because of the motion sickness desensitization program we have in the Dutch Air Force. I'll go deeper into that program later on, but what people typically do during that program is that they have the chair is rotating and they have to do fore-aft movements with the upper trunk, so you get Coriolis cross-coupling. They get motion sick, and it's used for student pilots that although they got into initial training, they do get motion sick. And so if they are further enough into the training, it can be quite expensive just to expel them from training. The success rate is very high, about 80%, and it takes for 2 weeks course, and it's been done for more than 20-25 years now. So I thought maybe the upper trunk movement also induce some sort of hyperventilation, and could that possibly account for the 20% that do not succeed succeed in the desensitization course. So what we did is we had a rotating chair, 60 degrees per second, increments of 5 degrees per second per minute to this maximum, and moderate nausea level was the endpoint. So it's a 1 to 6 level. 1 is I'm okay, 6 is I'm vomiting, and we stopped at 4. And we measured cardiopulmonary measurements, so heart rate, tidal volume, respiratory frequency, and tidal CO2 for measuring hyperventilation. Yes, next slide, please. Well, the results, in a nutshell, hyperventilation occurs only in a very minority of cases, but it's not an important cause of the symptoms. What we saw is that if we just have them perform a hyperventilation provocation test, they do not get ill at all. They get a misery score of 2 out of 6. There's actually no true nausea there. But what we did see is that only in a minority of cases some hyperventilation occurs, but it's very low, and we don't think that will in any way contribute to the symptoms. So in general, we think that it's not a big problem. But in those cases that do not respond to regular training, because it occurs in a minority of cases, you might just wonder and take a Nijmegen questionnaire for hyperventilation. It has about more than 95 sensitivity and specificity for finding hyperventilation syndrome. So if people do not respond, you might do that, take that questionnaire. It takes 5 minutes to fill out. Next one, please. So this was another experiment. Sorry, I think this one is a bit too early. Yes, so this is a sled that goes back and forth, and we can, and this one can turn also. Yes, next slide. So we wondered, as is done with tilting trains, that they can, if you go in a curve, then you get those gravity inertial forces that you can compensate for, and it is thought that on average, partially compensating for those forces will delay your occurrence of motion sickness. So this is what we also did. This was, we had 3 experimental conditions. It was a single blind study in a crossover trial. So we had no alignment, 50% alignment and 100% alignment. Next one, please. No true hyperventilation occurred. A small drop in end tidal CO2 levels, about 10% relative CO2 levels. It's something that we have seen throughout all our experiments. We think that's adaptation of the body for the nauseating stimulus. There was no true significance. There was no significance between groups. But if you look at the survival rate, so this is the A1. Yes, the partial compensation. This is this graph, and this is the full compensation. You see that the 50% survival rate is here about 13 minutes, and here it's about 20 minutes. It was not significant, but the trend is in accordance with the literature available. Yes. And the effect is temporary, because in the end you see people do get sick. Yes, next slide please. So what we also saw, which was quite interesting, that we were able to predict nausea. So if a misery score of 2, which means initial symptoms, so headache, tension, feeling in the around the eyes, if that occurred within 4 minutes, people would drop out, about more than 90% of them. And if there was no misery score within 6 minutes, they would survive, which was quite an interesting finding. You might hypothesize and think, well, could we use this for a pilot selection? I don't know, but it was a nice finding. Yeah. Next slide, please. So we did not find a true relationship with the hyperventilation, so we thought, well, maybe we need other motion types, because the O'Hanlon and Macaulay study was vertical. Do we maybe need higher G? So we used this Desdemona facility. Next slide, please. Yes, you could start this. It gives you, you already saw what the motion capabilities of the Desdemona are, but this gives you also a nice feel of what it can do. So it starts with a barrel roll. So it can go up to 3G, I think, yes. Next slide. So it has 6 degrees motion. What we did horizontal runs, vertical runs, and counter rotation, because it's about 8 meters length, the arm. So if you want to have 0.8 hertz, you need 0.05 hertz with a horizontal run. You need quite a long arm, so you can compensate that with counter rotation. I will not go into that because it's quite a physics thing, but it's all been described in the thesis. Yes, so it was this motion profile, 0.05. 0.1, 0.2, 0.4 and 0.8 hertz at 0.3 G. Yes, next one. Again, no nausea with the provocation test. We saw synchronization of the breathing frequency with increasing motion frequency and corresponding decrease of end tidal CO2 levels. There was no difference between motion types, and motion sickness maximum at 0.2 hertz. Yes. Next one. So this is what we more or less saw. Next one. And this is the drop in CO2 levels. There's a relative drop in CO2 levels. And what we see here is there's a tendency to increase with increasing frequency. So in a minority of cases we did see true hyperventilation, and with increasing frequency there was truly a tendency to synchronize with the frequency, which I have a little movie. Next slide, please. And this is again, these are the data points, and you see that it corresponds quite well with the nausea, it's yes or no nausea, with the 0.2 Hertz in motion sickness incidents. Right, next one. So what we will see here is that the gimbal is moving up and down, and her chest is moving with the gimbal, but she's hyperventilating even after, and she has a misery score of 4. She's hyperventilating even after the cessation of the movement. It just continues. So luckily we concluded, because that would, if we had concluded otherwise, it would have turned the concept upside down. So luckily we concluded that motion sickness is the main cause of symptoms perceived during complex motion stimuli. In a minority of cases, hyperventilation occurs, and irrespective of motion type, during low frequency oscillatory motion, motion sickness peaks at 0.2 Hertz. Right. Next one. So because I started working as a physiatrist, and this research was done while working as a flight surgeon, so I wondered, working as a physiatrist, is it possible to integrate this aerospace medicine research, so to speak, for patients, for true patients? So, next one. So this was the question I asked myself: can principles of military vestibular desensitization and information from this research be used for patients with vestibular disease? Next one. So first we have to look at the vestibular desensitization program of the Netherlands Air Force. This is one we talked about. Because the students have normal vestibular organs, so any adaptation takes place at the brainstem or subcortical levels. Which is quite interesting, because patients with vestibular disease have normal brain and subcortical structures. So could there be, as the adaptation is the same, could we just do a desensitization course with patients? Next one. So what is the desensitization course for the student pilots? It's a rotating chair, starts with about 60 degrees per second, goes to 180. Endpoint is nausea level, 2 weeks. So this is what we do. I cannot do this with patients, because I cannot do it with myself, because if I start at 60 degrees, I'm done in 20 seconds. So we had to do something else which was more friendly to patients. Next one. So to do that, you have to ask yourself, okay, what's the best evidence available right now for treating chronic vestibular disease? Well, this is what comes out of the Cochrane review: self-administration of provocative head movements. However, next slide. If head movements are too provocative, so self-administration is potentially very difficult. So if you do this or this and you get very nauseated, it's quite difficult. Next one. So this is our virtual reality system. This is the CAREN system, a computer-assisted rehabilitation environment. It's a hexapod system with a treadmill, single belt treadmill with 4 force plates underneath, 6 meter, 180 degree screen, and about 12 infrared motion capture cameras around it. Yes, next one. So what we did is we have seen that it's 0.2 Hertz. We do want to get them nauseated, so we start at 0.2 Hertz. And we increase the amplitude of the motion. We chose a vertical motion with 10 centimeters, and we went to 40 centimeters because that 40 centimeters was the maximum we could do with the system. We discontinue the session when a misery score of 4 is reached, and 10 sessions max. Next one. People fill out a questionnaire, the Dizziness Handicap Inventory. It measures physical, emotional, and functional aspects of their disease. This is no problem, this is severe problems, and a 10% decrease is seen as clinically irrelevant. What we have seen until now, yes? Next one. We have done about 10 patients until now. I think that by the end of the year we will have about 15 to 20 patients, and we see a 20 to 80% decrease in the DHI score, and it keeps that way for what we can say now for about at least a year. So that's quite nice. No pharmaceuticals, just that motion, 10 sessions, and it's either at 3 times a week or 4 or 5 times a week, and people have a significant decrease in their symptoms and a better functioning afterwards. Yes. Next one. So, can these principles be used for vestibular? Yeah, we think it's possible. We are busy building our case series, and hopefully in the future we can do a randomized clinical trial to see if it holds up in such a trial. Next one. Of course, not only vestibular system is of importance in keeping your balance when you have a vestibular disease. Next one. You can start, if you not started, but just show it so I can explain a bit. Yes, please stop it here. So what we have here is dots. These dots turn. It's a roll down. We know this from research that's been done in the 70s, but it's done with standing patients, of standing people, and eventually people can fall. And we wondered what happens if we let people walk, because it's never been done before. Yes. So actually that's me walking, and what you will see is that when it starts to walk, maybe we can have a dimmed light. What you see is that you can see but the gait changes, and you see a slight shift into the rotation of the dome, and eventually you will fall off the dome. Well, me. And it takes, I think, my 5th time on this thing, and I'm shifting slowly, and eventually I will fall off. Yeah, there I go. But what happens with this is that you have an illusory feeling of self-motion, faction. Yes, yes, you can start this one. Same thing. This is one of our physical therapists. And it's one of our physical therapists. It's a typical physical therapy walk, I guess. So, and what you will see is that there's direct influence on his gait, but also I'm filming. I'm also influenced by the faction, because I have this. You see, I'm holding the camera in my hand, and it just tilts. I go, oh no, it's not okay. So that's a very strong illusion which happens each and every time. But you also see from this that it's just keeping your balance in normal situations and daily life is a very delicate thing. So maybe you could stop this one, yes? So what we will do here is balance and orientation in daily life is for a large part done by vertical lining. So what we did here is we have a lot of vertical lines. He will walk through pillars, also vertical lining. What we did is just translate a slight translation of the scene to the left or the right at random, and just look at the what happens. But it also gives you the info. Yes, please. Look at what happens, but it also gives you an inclination of how important stable environments in daily life are. And it gives you this is one of our former physiatrists. He's retired now. Yeah. And it's quite instantaneous, as you can see. And just slide left and right. We were just kidding around with him. Okay. Yeah. Yes. Well. Okay. This was a presentation. Yeah. Any questions?
No. So maybe we can get the question back. 86% already agreed that it's a miracle that we can find our way home at all. 91%. Wow.